Well, it is 12:01. We are going to be extremely punctual this afternoon. So, welcome everyone to our VCSQI Quality Committee. Thanks all for being with us here today. We have a special guest from UVA. And Judy, I'm gonna toss it over to you. I'll put you on the spot here. Are you able to just provide a brief intro for Dustin before we toss it over to him?
Okay. Now, were you willing to share any outcome slides or no?
Yeah, I'm definitely willing to share the outcome slides, but how about since our guest is with us, I
Okay.
prefer we have our presentation first, and
Okay, perfect.
anytime I can fill at the end with data.
Okay, perfect. Okay. It is my extreme privilege and joy to introduce Dustin Money. I can remember working in TCP ICU with Dustin as a respiratory therapist, and Dustin's someone who's always on top of his game and always focused on the patients. And the other thing is he moved on to be an ECMO specialist. Dustin, one of the things I really remember about you is standing in front of that ex vivo thing where we had those like black lungs that you were actually doing like the extracorporeal circuit to kind of resuscitate the lungs. Dustin's been very involved in research, now is at the bedside, does our ELSO database. I mean, I could go on and on about Dustin. Dustin, you might want to say more things about yourself. But I think what stands out for Dustin is just his care for the patients, his commitment to research and doing the best thing for the patient, learning and growing and sharing that knowledge with others. So today I'm super excited to have Dustin Money share with us about ECMO. And he does kind of know some of I showed him the fields that we have in our STS database, what we have to abstract and what we kind of have to wrap our heads around. And we can talk a little bit about the specifics of that at the end if we have time. So, Dustin, take it away and share your screen and do your thing.
Perfect. Let me go ahead and share my screen. Okay, can everybody see that?
Yes, I see it.
Excellent. Okay, my name is Dustin Money. I'm a senior ECMO specialist here at the University of Virginia. I've been here at the university for about 17 years, and kind of one of my things, I'm also 9 months out of cardiac surgery. And so I can tell you that the work you guys do here at VCSQI, data collection, uh, coming together to work on problems that are affecting cardiac surgery here in Virginia is absolutely important to me. And I have benefited from that personally. I have no disclosures, but I am a member of an ELSO committee, and I will be talking about the Extracorporeal Life Support Organization. So some may feel that that might bias me, and my salary is partially supported by the NIH. But again, I'm not making any money off of Medtronic or any commercial resources. It shouldn't be a surprise to anybody that ELSO and ECMO has grown substantially over the last 10 years. A matter of fact, more patients have been placed on ECMO in the last 10 years than the preceding 20 years prior. You can see here in the orange, this is the number of cases. So, and this goes up to 2023. So in 2023, there was 20,000 ECMO cases throughout the world. Also, the number of centers have grown substantially. In 1990, only about 1,000 people went on ECMO at that time, reported the Extracorporeal Life Support Organization, and there were less than 100 centers throughout the world. But really, what is ECMO? Some people get confused about this. ECMO and ECLS are sometimes used together in the literature. ECLS meaning extracorporeal life support, and ECMO meaning extracorporeal membrane oxygenation. ECLS is the over umbrella term, where ECMO and external VATs and external pumping devices are part of that. But really, ECMO refers to the placement of any sort of membrane lung within a system. So if you have a CentraMax system that is set up as a right-sided device that is external, and then you add an ECMO, you add an oxygenator into that, that now becomes ECMO. It is support for the heart and the lung. It is when conventional therapies have failed to keep the patient alive and keep them stabilized. It stabilizes and supports the life by improving end organ perfusion. It lessens iatrogenic injury. And most important, it's a bridging therapy. You are bridging to a decision. You're bridging to recovery. You're bridging to transplant. But hopefully, you've picked the right patients that you're not building a bridge to nowhere. But what ECMO, what is it not? Well, it's a cousin to cardiopulmonary bypass, but it is different than what we're doing in the operating room. ECMO is a closed system. It's directly connected to the body through cannulas. There's no air-blood interface. Therefore, you use less anticoagulation. Though the centrifuge pumps are preload dependent, afterload sensitive, Bypass machines, because you have an open reservoir, they have to be lowered to the ground. It is not an intracorporeal system in intracorporeal VADs like the HeartMate 3. It is also no longer the end of the road. ECMO should no longer be used as a salvage therapy to be used in the most extreme cases, but should be to be used as an important tool in the toolbox of critical care medicine. Over the years, the indications for ECMO have increased substantially. What used to be used for patients as a last resort when nothing else is working is now being tailored to be used as an early intervention device. There's a lot of information coming out on data supporting the use of ECMO for adult patients with severe ADS, as defined by the Berlin definition of a PF ratio less than 100, refractory pulmonary embolisms, drug overdoses, more use of ECMO in cardiogenic shock, of course, in cardiothoracic surgery and failure to wean from bypass, being used for bridge to transplant, bridge to heart or lung transplantation, still heavily utilizing neonates and pediatrics and patients with meconium aspiration and persistent pulmonary hypertension, having the best outcomes overall for ECMO. And of course, rising evidence, especially the group of the Minnesota Resuscitation Consortium, the use of ECMO in ECPR and refractory cardiac arrest situations. Contraindications. In the beginning of ECMO, there were tons of absolute contraindications. With changes in technology, improvement on how we actually care for ECMO patients, the number of absolute contraindications is pretty much dwindling. Absolutes, DNR, that's kind of obvious. Irreversible organ injury, multi-organ dysfunction, genetic disorders that are not compatible with life, which you see typically in the neonatal population, and terminal disease processes. Really, relative contraindications are like advanced age, prolonged toxic ventilation. There's controversial evidence out there, patients on a vent for 7 or 10 days. Past that window, there could be potentially worse outcomes for patients that are on long-term mechanical ventilation. But if you look at places like the Karolinska Medical Center over in Sweden, they're putting patients on a vent for 30 or 45 days and using ECMO as a weaning device to get patients off mechanical ventilation. Those with severe coagulopathy, ECMO sometimes requires anticoagulation to lead to more bleeding, and those that are already bleeding and having a coagulopathy may become worse. Obesity, frailty, and comorbid condition. Supporting patients on ECMO is really about plumbing. The circuit itself, we pretty much use an oxygenator that can supply 250 to 300 milliliters a minute per meter squared. So you're able to provide a baseline or slightly enough oxygen support for moderate amounts of exercise. ECMO includes a patient, plastic tubing, cannulas, a pump, an oxygenator. The inlet side, the venous drainage, is a negative pressure into the system. The pump is drawing the blood to the pump through that tubing. That same pump is sending positive pressure forward to the oxygenator, where gas exchange occurs, and then out of that oxygenator through the return tubing to the return cannula. ECMO and the contact phase activation. So, ECMO. This is a visual summary of the interaction between hemocompatibility and thrombogenesis during extracorporeal life support and the adopted strategies to control it through anticoagulation agents and coding methods. Blood does not like to run through plastic tubing or be outside of the body. So just by the blood touching that plastic tubing, the pump, you have thrombocyte activation, protein absorption, inflammation, and shear stress that can occur. Over time, we've realized that in our technology, and the tubing itself is endothelialized almost to mimic like the blood vessels. So here on the right, there's kind of two different examples of the type of coding that we use on our system. We have active coding and passive coding. Active coding has heparin and these sites that are actually on the tubing itself that prevents thrombin formation and platelet adhesions to the surface, allowing you to not have thrombin generation as much as you did in older systems. Because you have this effect on the hemostatic system of your body, and you do promote thrombin generation, you need anticoagulation like heparin and bivalirudin. Blood pumps. Over the history of ECMO, there's been many different types of pumps that have been used. The roller pump was the tried and true beginning of ECMO. It's beginning of cardiopulmonary bypass. They're displacement pumps. They're preload dependent, afterload insensitive. It's going to pump whatever it needs to pump, whatever the afterload is going to be. You have other types of pumps, like the second picture there. That's a Berlin heart. That's a pulsatile air pump. not something that you'll use in ECMO, but a blood pump that's out there that's an extracorporeal life support device. Then you have something like the Impella. Right? The Impella is an axial screw with ceramic bearings in which it spins on. That's intracorporeal life support because the pumping mechanisms within the body itself. And then over here on the right, you have three different centrifugal pumps. The top one is the first centrifugal pump to come to market, the BP80 pump head from Medtronic, that had concentric rings that would spin, and shear forces would cause viscous drag to actually push the blood outwards. And then you have the two current workhorses that are on the market, the Rotaflow and the Centromag. They're very similar pumps, with the exception of the Centromag, formerly known as Levitronics, uses a magnet that lifts the pump body up within the fluid/blood itself. That spin of a centrifuge pump applies negative pressure. That negative pressure pulls the blood down into the system, and also that centrifugal force gives high outlet pressures that sends blood out to the system. The membrane lung, and this is really what ECMO is all about. How does this work? Well, it's kind of very simple physics. You have several inlets on this thing. You have the blood inlet that goes onto the face of the oxygenator. That is venous blood. That blood is going to go around the fibers. You're going to have gas that's connected to a flow meter that you can give 21 to 100% oxygen. That's sweet gas. That gas is going to go through the fibers. There's no carbon dioxide in that. That's going to sweep the CO2 off the blood and add oxygen to the blood, as that gas is going to diffuse through the hollow fibers of that membrane. So that what you get out of the bottom of that oxygen on the arterial side is the blood gas that you're trying to give to that patient. Also, in these modern oxygenators are also the ability to heat and cool the blood. So there's a gas phase, there's two blood phases, a venous and arterial, and then there's a water phase that is a bath that goes around the housing of those fibers that heats and cools your patient. I bring this up, polymethylpentene, because polymethylpentene fiber is what the new current oxygenators are made out of, and is this technology that led, one of the reasons that led to the propagation of ECMO throughout the world. There's two different kind of styles of these fibers. You have long fiber, which are over here on the left side. These are Urosets. These are kind of wound around a heater coil. They are longer fibers. They're higher resistance membranes. They're not going to last as long as the ones on the right, which are short fiber. There are 6 commercial available oxygenators in the United States. These short fiber ones are low resistance. They can go for longer periods of time, but they're harder and more expensive to make. Cannula selection, it really depends on what are we using ECMO for? Are we using it for respiratory, or are we using it for cardiac reasons? Are we cannulating ephemerally or in the neck or central? What's your patient size? How old are they? What are your flow needs? Vessel size, anatomy. The same laws of physics, like Pucell's law for resistance, are the same reason how we pick cannulas. A cannula that is longer with smaller resistance is going to tolerate less flow rates and have more of a pressure drop. We use these types of charts up at the top to help us choose the appropriate cannula based off of the flow that we'd like to give to our patients. Temperature regulation, I touched on this very briefly as far as heating and cooling patients through the oxygenator itself. All oxygenators except for the Spectrum oxygenator that's out on the market, it's integrated into the oxygenator. It's affected by blood and the water flow. And a lot of people forget that even though you're heating and cooling a patient through the oxygenator, you still have radiant heat loss out through the patient themselves if you don't cover them up. Not all devices are equal. You have some, like the little white microtemp LT, that's not going to heat and cool your patient as effectively as the one on the right, which is the cardio-equipped modular heater cooler. They each have their own power and gallons per minute that they're able to push through the system. Smaller patients, are you going to be able to mask a fever? You know, there's an old wives' tale that you can't fever on ECMO, and that's not particularly true, especially if you did any time during COVID and you saw these patients hit 40 degrees Celsius despite having a heater cooler in place. They are active heaters, passive coolers. And so they're not like the heater coolers that you see downstairs in the operating room that have refrigerant in them and are able to easily cool the body as well. And there's an infection risk associated with these products as well. Types and modes of ECMO. So ELSO recognizes 3 types of ECMO. So you're either going to get respiratory ECMO, so only ECMO for pulmonary reasons. You're going to get cardiac-based ECMO, or ECPR. And ECPR is a pretty strict definition. That is mean you're applying VA ECMO in the midst of cardiopulmonary resuscitation in which there has been less than 20 minutes of ROS or no ROS. Modes of ECMO. This is where people get confusing. In 2019, there was what they call the Maastricht Coalition of Nomenclature for ECMO, and no one has actually fully obeyed this. It's kind of a complicated ask of how they wanted to start having people describe what type of ECMO you're on, but essentially it starts from left to right. So the first letter tells you what are you draining. So on VA ECMO, veno to arterial, it's cardiorespiratory support. I'm pulling from the venous system, I'm giving back to the arterial system. Veno to veno, I'm pulling from the venous system, getting back to the venous system, and that's for respiratory support only. There's no support for your blood pressure. Now we start getting into other types of ECMO. V to PA ECMO, that is draining from the venous system, giving back to the pulmonary artery. That is used for percutaneous RVAD. In external RVAD that is tunneled out through through a central cannulation technique, it's either for right side support or respiratory support. At our institution, we've been doing V to PA ECMO as bridge to heart transplant, bridge to lung transplantation of those that have mild to moderate pulmonary hypertension. There's also something called extracorporeal CO2 removal, or ECCO2R. That can be a pumpless system used through something called the Nova Lung that the military was using a long time over in Europe. When you get these soldiers with blast injury, you cannulate the artery, you cannulate the vein in the leg. It's a pumpless system. The heart itself, maintain a mean of 80, will pump through that oxygenator, and it's for mostly CO2 clearance with a little bit of oxygenation clearance. Now, there's other things you may see as you start looking through people's charts, and you'll see things like VVA. Well, that could possibly mean if it's V and V2A. So V and V means two venous drains back to the arterial system. You can have VVA, that's V2VNA. That means you have one venous drain, and then you're returning to the venous and the arterial system. Different cannulation strategies that you see on VA ECMO. So the two most common is going to be your peripheral and central. Peripheral cannulation, you're cannulating femoral vein, and you're returning to a femoral artery, and you typically require a distal perfusion cannula to perfuse the leg in which you have the arterial cannula in place. The second most common is central VA ECMO, which is very common in patients that are failure to wean from cardiopulmonary bypass, in which you directly cannulate the right atrium and the IVC, and you're returning your blood back to the aorta, either direct access into the aorta or through a graft site. You start seeing things like peripheral femoral axillary, where you're draining from a femoral vein, giving back through an axillary artery. Those are more time-consuming cannulations, which require you to have an operative procedure to put the graft on. And there's typically patients that you're bridging to more long-term therapies, like bridging to an LVAD, bridging to more long-term recovery, and possibly may end up using that graft site to put an Impella 5.5 in. Or you're bridging to lung transplant or bridging to heart transplantation. The other one is peripheral jugular axillary VA ECMO. You're draining from your neck in an IJ cannula, getting back to that axillary site. And then in pediatric patients, so patients that are 20 kilograms or less, specifically those we see in our neonation, you're doing jugular to carotid, and you're using cannulas that span in the size of 8 to 14 French. North-south. So north-south is a pretty common complication that you're going to see on femoral VA ECMO. North-south is when, you got to remember, if you're femorally cannulating your arterial space, you're running blood retrograde up the aorta, which you're seeing here on the right-hand side. So here's a cath picture of them putting contrast dye in on somebody that's femorally cannulated. And you can see up on the top left of that picture, you don't see the contrast dye get all the way to the heart. There's a mixing cloud up there at the top of the great vessels, where you're mixing with blood that's passing from the right side through the lungs and dumping into the left that the ECMO pump is not catching. If you have a patient that, let's say he's a 20-year-old, he's a trauma patient, his lungs are completely whited out, but you put him on an extremis because he's on high-dose vasoactives. The minute you start draining blood from the right side of the heart, you're going to have a bounding blood pressure. Your mixing cloud's probably going to be right there in the middle of the thoracic aorta. as they are able to generate higher pressure against your ECMO blood flow. So now you have more hypoxic blood going up to the top of your body and all of the ECMO blood flow down there towards the lower half of your body. Judy wanted me to bring up a little bit about LV venting and offloading. This is a pretty hot topic kind of in the ECMO community. And this is a really good paper by LaRusso and colleagues. So a European paper. It's a meta-analysis kind of looking at LV unloading and kind of what's the current evidence. And really, the overwhelming message of the paper is LV unloading should always be applied during VA ECMO on the basis of higher rates of weaning survival and bridging to advanced therapies despite potential complications. Well, why do we want to do that? So if you have somebody you did, let's say, a really low EF CABG, and you're not able to get them off a bypass, and their EF coming off a bypass is 5%, that weak heart's going to have a hard time pushing against the afterload you're creating with VA ECMO. Yes, VA ECMO is stabilizing your patient, getting them off of bypass. It is resting the heart, but the heart is now pumping against your high pressure, high flow rate of your ECMO pump. That's increasing afterload to the left side of your heart. Because of that, the heart may not be able to empty appropriately, and you have stagnation of blood flow that could occur. There's a bunch of different ways you can vent the heart, and it really depends on how your patient presents. And I'm not going to get too far down in the weeds with this, but there's direct unloading and venting, and there's indirect. So indirect unloading with things like a balloon pump, if things like medication, so tube of epi in the background, a little ionotropy to allow that heart to push against your ECMO, your ECMO flow. Direct unloading would be things like putting in an Impella 5.5, putting in a cannula directly into the left ventricle or into the left atrium to drain that blood flow off back to the ECMO pump. Now, it's not without complications. So bleeding and thrombosis being one of the bigger ones that you can see when you're venting a patient. However, despite that, you're going to have higher rates of weaning and increased myocardial recovery. It's another paper from Pappalardo. So Pappalardo and all show that patients supported with an ECPella strategy. So you're going to see a lot of this nowadays. ECMO plus the use of an Impella. So either a patient starting on ECMO was rescued from extremis, stabilized, and an Impella pump is placed, or they're on Impella, they fail, they go on ECMO. Pappalardo showed that patients supported the ECPella strategy not only had improved outcomes, but also showed a trend towards higher left ventricular ejection fraction after weaning. In this experience, investigated 34 ECPella patients. At propensity score matching, ECPella group presented significantly lower in hospital mortality, 47 versus 80%, and a higher rate of successful bridging to either recovery or full therapy, 68 versus 28%, as compared with VA ECMO alone in patients. So a further study by Schrag et al. That recently reported the most important evidence from the combined use of Impella and VA ECMO. And in this international multi-center cohort, 255 propensity matched patients supported Impella were compared with 255 patients supported VA ECMO alone. And LV unloading was associated with lower mortality in patients with cardiogenic shock treated with VA ECMO despite higher complication rates. VV ECMO is a little bit different. VV ECMO is for respiratory support only. Your cannulation strategies, you can either use one single lumen or a double lumen cannula placed into the right IJ, in which you're draining from the SVC and the IVC and returning back into the right atrium across the tricuspid valve. You can do femoral jugular, so a cannula in the groin and a cannula up in the IJ, where you're draining from that cannula in the groin and returning to the top into the right atrium. You can go femoral VV ECMO. I have a patient, let's say, with a right IJ thrombus. I'm not able to put a cannula in up top. They're in extremis. I can put two cannulas in the bottom, one higher than the other. My drainage cannula is the lower one. My reinfusion cannula is at the top. And then femoral PA VV ECMO, which is basically an RVAD. One of the most common complications of VV ECMO is recirculation. Since you are pulling from the venous system, getting back to the venous system, you're going to draw some of that ECMO blood flow back to your pump. If your cannulas are too close together, they're malpositioned, let's say you're too hypovolemic, those can increase your rates of recirculation. Also too high of blood flow, which means I'm just pulling back everything I'm giving to the patient. Therefore, your venous sets are higher than your actual systemic sets. I talked a good bit about what is ECMO. I think it's really important to discuss how we actually got to this point. I could go on and on about this. I will catch myself from getting too far into the weeds, but really ECMO evolved from the innovations of cardiothoracic surgery. You can go all the way back to the 1600s, the Jean-Baptiste and experiments with blood and transfusing from sheep into people. Really, we start crediting Dr. Gibbons. And so in 1930, Dr. Gibbons develops the first roller pump. And in 1953, the first human was actually placed on cardiopulmonary bypass successfully. Dr. Gibbons and his wife Mary were driven kind of by the death of a patient from a PE who nowadays would have survived with no problem. And because of that, developed a freestanding roller pump to provide extracorporeal support. The first patient placed on a system was an 18-year-old for the successful repair of an ASD. The 50s were a hot time to develop extracorporeal technology. And in 1957, Dr. Kammermeyer revolutionized the artificial lung through the synthesis of silicone rubber. Prior to this, that big machine, that is the first bypass machine. Back then, blood came out of the body and flowed in a thin sheet down the top of this membrane, in which gas was actually physically bubbled up through the blood to generate oxygenation. Well, air-blood interface, blood and air, that causes a clot. These devices were short term. We're not talking the pump runs that you can do now. We're talking minutes of time before patients could have complications. Some of our initial successes with ECMO. So between 1966 and 1975, 233 ARDS patients were treated with ECMO by 90 medical teams in 7 countries. But it really wasn't until 1971 that there was actually the first successful surviving ECMO patient. It's a 24-year-old male patient admitted to Santa Barbara Cottage Hospital after being struck by a motor vehicle. He developed ARDS within 4 days of admission to the hospital. Patient was dying, and the Navy, along with a group from the University of Michigan, brought over this machine called a Bramson lung out of their lab and flew it here to California to put this patient on support. After 4 days on ECMO, the patient was successfully weaned, and in 8 weeks, the patient was sent to an orthopedic hospital. From there, more patients, more successes were developed, were published. 1972, that little boy in the middle was the first postoperative cardiogenic shock patient who was successfully supported with ECMO, and he survived after mustard atrial baffle procedure. And then 1975 was the Esperanza case out of the University of Michigan, which was the birth of neonatal ECMO and Dr. Bartlett. Esperanza successfully used cardiopulmonary bypass in an abandoned newborn that they named Esperanza, meaning hope, suffering severe respiratory failure of meconium aspiration. She was decannulated, 72 hours of ECMO support, and she grew up to live a very normal life, and actually a key feature at many meetings. The first RCT for ECMO was in 1979, and this was probably one of the worst kind of trials that was ever put out there. We had antiquated mechanical ventilation strategies of 15, 20 mils per kilogram, no PEEP, low rate. And they basically, 9 medical centers throughout the country randomized 48 patients to conventional mechanical ventilation, and then 42 patients with bad mechanical ventilation plus VA ECMO. Well, nobody survived. And then since this point, there was a complete, real decrease in lack of good ECMO studies for a good 15 years. Adults weren't getting much ECMO and were done at maybe 10 to 15 centers throughout the world, but pediatric ECMO and neonatal ECMO continued to kind of take off over this time. By the mid-1980s, they were having a lot of success with infants with hyaline membrane disease. PPHN, meconium aspiration, meconium aspiration specifically, was starting to see survival of up into the 100% by the end of the 1980s. By 1990, there was a crossover. They were starting to see a lot more successful survivors to ECMO. All these pictures, this is ECMO of old, ancient antiquated silicone oxygenators, that white picture at the top, old ECMO carts, things that we look at now, we kind of cringe at just the size of them. The propagation of ECMO really took off through multiple different mechanisms. Around the year 2000, you started seeing the publication of the ARMA trial, low tidal volume ventilation. So it was a combination of things. Improvement in the way that we manage patients in a critical care aspect for mechanical ventilation, on top of additional studies and data that were coming out about ECMO. 2009 H1N1. the FAMREVA trial based out of France, the Australia-New Zealand ECMO trial with 60% survival to discharge for patients with an 80% chance of mortality from the flu. Then there was the classic seizure trial, 2009. Outcomes in adults with severe respiratory failure were better when patients were transferred to the care of a team specializing in patients where ECMO was part of the conventional treatment algorithm. Changes in technology also led to the propagation of ECMO, polymethylpentene oxygenators, centrifuge pumps, endothelialized tubing, different types of pumps coming onto the market. All of this led to the increase in ECMO that we see today. The same time, 1989 was the birth of the Extracorporeal Life Support Organization. So these were just a very small group of just 100 people that were interested in ECMO. These are throughout the world, people that were putting on patients and talking amongst themselves and mentoring each other through the use of this technology. This became an international consortium of healthcare professionals and scientists that are dedicated to development and the evaluation of these novel therapies for support of failing organs. This organization has grown substantially over the years and has gone just from this small group of people getting together to talk about ECMO to now it's also a database. So they also collect all the information about all the ECMO patients of member centers. They also are responsible for issuing clinical practice guidelines, statements, and reports. And they're also responsible for benchmarking for government regulation, industries, and individual hospitals. They also start awarding centers of excellence, platinum, gold, silver, different levels for different centers depending on how their program is structured and the type of work that they're doing. ELSO has also now become the largest database of ECMO patients in the world, with over 240,000 entries, around 11,000 patients a year, representing 700 centers in 60 countries. Just a quick look, but this is this morning I printed this off, 247,968 patients in the registry with 54% survival to discharge. Of course, neonates have the highest survival overall, but they are the least amount of patients actually in the registry. 72% survival to discharge for a neonate with respiratory pulmonary complications, and that's typically meconium aspiration and persistent pulmonary hypertension. The population does the worst is adult ECPR at 31%, but this is evolving. And so you have Dr. Yiannopoulos, the Minnesota Resuscitation Consortium, they're reporting 50% survival discharge for patients with a less than 5% chance of survival in out-of-hospital cardiac arrest. All your ELSO centers in the world, ECMO is done pretty much everywhere. And a growing number of ECMO centers reported ELSO every year. Kind of looking at international volume, if you look over here, the graph on the left is neonatal peds in the yellow, orange, and green for adults. You can see around 2013 was the transition point in the registry in which there were more patients and more centers doing adult ECMO versus children's hospital-based ECMO. On the right, you see the different ELSO chapters. So there's not just ELSO North America. There's Euro ELSO, there's Asian Pacific ELSO, there's Latin American ELSO, there's South and Western Asian ELSO. Since 2013, there's been an increase in ECMO in these different areas, specifically in Southwest Asia and Asia Pacific and throughout Latin America. Looking at ECMO here kind of in our little mid-Atlantic region, there's 4 centers of excellence that we have here in Virginia. UVA and Fairfax are your platinum centers, with VCU, Creeley, and CHKD kind of being your gold centers of excellence. Outside of that, there's 10 kind of centers within kind of Virginia that have the capability of doing ECMO, 7 of which report directly to ELSO their outcomes. Looking at the evolution of the registry, around 1990, the registry was pretty small, around 50 to 100 variables. As time went on, they began adding different sort of addendums, a cardiac addendum for those that just had a cardiac diagnosis. After 2005, they added an ECPR addendum as that was a growing trend that they were seeing. 2009, with H1N1, they put a specific addendum out to that, just like they did with COVID. They started using severity scoring around like 2017, and that's actually been deleted from the registry since then. And then around, say 2016 till now, they've been adding different things into the registry. So they've added dates to procedure codes and dates to complication codes, information about lactate, saturation, did you prone your patient, more information about are you enterally feeding your patient, if so, when, mobilization, or how much mobilization they had while they were on support at 24 hours, 7 days, and max mobilization during their run. I like this slide because it really shows the growth of the registry. So kind of looking back to the birth of the registry in 1989, 1990, there's been a significant increase in the amount of publications based off of the ELSO registry. And the blue is adults, not a lot of adult-based publications until 2009, after H1N1 seizure trial, adult ECMO started taking off, and a lot more publications around adult ECMO. What is the ELSO registry? I'm running out of time, but I'll be pretty quick here. There's 525 ELSO registry variables, kind of baseline. Some patients can have more. The longer the run, the more things you're going to have to report out, but it's based on patient demographics, pre-ECMO clinical data, in which we're capturing primary and secondary diagnosis using ICD-10 codes, pre-ECMO support, vasoactives, are you on CRT, those sorts of things. Did the patient suffer cardiac arrest? Did you transport to your hospital? If so, how? Hemodynamics, what's going on with the vent, EVG. There's daily data capturing stuff at the 24-hour period of time, your blood flow, every procedure, every CPT code that they've had while they were on support, culture data, ECMO support data, mode, type, cannulation set, equipment. We capture complications. There are 9 different categories of complications and about 30 different complications overall that we capture. And then your outcomes: survival, reason you decannulated, survival to hospital discharge, which you're going to stay, discharge disposition, and extubation tracheostomy data. And then there's 4 different addendums, one for cardiac, ECPR, trauma, and then if your center's participating in different research stuff with ELSO, there's addendums for those as well. There's a new quality reporting dashboard. We used to use something called Arbormetrics. We've now switched over at the end of 2024 to using something called Domo. Everything that I put into the registry will be dumped between 1 and 5 in the morning into Domo. And really, Domo allows us, we're able to pull everything we are. So instead of the old days, we used to have to download all of our own data from the registry, play with it ourselves to make reports. Domo now allows us to pull those reports directly from the system itself without us having to play. And this just came out. There's a new update coming out at the end of spring. I'm really excited about that. There's also AI that can be leveraged with this. We're not even close to really seeing what this is going to be able to do for us in the ECMO community. And so in closing, I really appreciate everybody for allowing me to speak today. I hope this was entertaining and educational for everyone. We are always constantly looking to collaborate, and we're looking to make peer groups through ELSO and other ECMO centers to benchmark, work on research, and improve our care for ECMO patients in the Mid-Atlantic region. And please feel free to reach out to us. And I thank you all for your time.
Thank you so much, Dustin. That was awesome. I, of course, have questions. Does anybody have questions for Dustin? Dustin, could you talk a little bit more about the difference between bypass and ECMO, and why we have some patients, not here at UVA, but it's like in the training manual that some actually like intraprocedural support uses ECMO instead of bypass. But if that's 2 questions, could you talk a little bit more about the difference between bypass and ECMO,
Sure.
and
So
why you would use ECMO instead of bypass to support a patient during a procedure
the big
intraoperatively?
difference: air-blood interface with a bypass circuit. Blood is draining out of the body on a bypass circuit to your cardiotomy, your reservoir, where blood gets in contact with air. It's going through a filter into the bucket. From that bucket, it goes through a piece of tubing to the pump head. From the pump head to an oxygenator, out from the oxygenator to a filter. Because of there's an air-blood interface, it requires you to have larger amounts of anticoagulation in the heparin. So greater than 400 seconds of an ACT. Because there's no air-blood interface with ECMO, with, let's say, a patient that's on VV ECMO. I just had a trauma here a couple weeks ago that I put on here. A guy in his 70s, bleeding. I put that patient on with no heparin, got no bolus dose of heparin, and ran almost his entire run without anticoagulation. It's because of the fact that that's a closed system for ECMO. And so I'm not saying he didn't make clots in the oxygenator, but since the systems now are endothelialized with coating, you are able to get away without anticoagulating certain patients because there's no air blood interface. The second thing is on ECMO, since you're a closed system, my RPMs dictate how much I'm draining to the system. The RPMs also dictates my flow forward to the system, which is affected by SVR. On a bypass circuit, your drainage and your forward flow are relatively independent from each other. Another thing is using ECMO versus bypass for certain procedures. At UVA, we will put patients, it's patient specific, pathology specific, but we'll do lung transplants here on ECMO. Fair amount of them. Last year we did 16 on ECMO. Why is that? It goes back to the use of less anticoagulation on ECMO versus bypass. I'm not achieving for a lung transplant. I don't need full flow as if you're cardiopleging the heart and doing a CABG or a valve. You need a little bit of flow to support the heart as the heart's being pulled over during dissection, as you're clamping off one of the lungs. So it's the advantage of using less anticoagulation, supporting them at lower flows that you have versus bypass, if that makes sense.
Yeah, though I guess, I mean, ECMO still puts oxygen into the blood, but that's not an air-blood interface. That's some
No,
other
because
inter.
the air is not touching that directly. It's through a membrane, through a true membrane. And actually, oxygenators in the operating room are different than the oxygenators used for ECMO. So
Okay.
oxygenators in the operating room are made of polypropylene, which are very similar to
Okay.
the fibers in a CRT machine. They're porous, hollow fibers. So if you were to look at those under a microscope, there's little holes in there. And so
Uh,
you can get air embolism that basically can kind of come out of those fibers. Well, why do
uh,
you use those versus like the ECMO oxygenators? Well, expense. You also can't put anesthetic gas through a polymethylpentene fiber as you can with a polypropylene fiber.
okay, thank you. Could you talk, one of our other options is VAV. And you didn't talk about that, but anytime you're adding a cannula, there's a reason that you went from VA to VAV or VVA. Like what,
The,
why?
the question has to, so if you're saying VAV, these are the things you
Yeah.
have, when you look in the chart, is it V2A and V, or is it
Okay.
V and V2A? So the difference is V and V2A, V and V
Uh-huh.
is two drains wide together. I'm
Uh-huh.
draining from two different parts in your body and I'm
Okay.
sending it to the arterial system. V2A and V is one venous drain to the membrane that goes to one arterial cannula and one venous cannula back into the body. So why would I do that? So let's say I have somebody with really bad north-south, like I talked about. They have whited out lungs. They have I'm able to, I'm mixing maybe mid-thoracic aorta or just on the other side of the three great vessels. So their head and their upper half of their body might be seeing a SAT in the 80s or 70s. Well, how can
Uh-huh.
I fix that? Well, one of the ways is I can add a cannula in the right IJ, and I
Uh,
still have my femoral arterial cannula. And now I'll split that. And now I'll send blood to my arterial cannula and this other venous cannula in my neck. So I'm basically doing VV ECMO and VA ECMO simultaneously, but I'm using one venous drain to do that.
that makes sense. Thank you. One of the other things we have, and you mentioned it yourself, not just as an LV vent, but the Impella. In my mind, an Impella is a VAD. It's not ECMO
Correct? It's a
because you cannot put an oxygenator on that like you could a Centromag.
no, but you can offload the left ventricle that you may just have no flow. The aortic valve might not be opening all the time. Every third beat, the aortic valve's opening up because
Mhm.
I'm flowing, let's say, 5 liters up the aorta. retrograde. I'm increasing afterload to the left side of the heart. At EF, let's say it's 5%. That person can't generate the force to go against my
Hmm.
ECMO flow. Because of that, the heart fills. And then I'll eject on the fourth beat. My valve will now open. What's that going to lead to? You're going to see smoke on the echo. You're going
Uh,
to have clot. You need to get that out. And so old days, the old ECMO, we'd have to do a transeptal cannula, take them to the cath lab, perf the atrium, drain the LA directly back to the circuit. Well, with
mhm.
Impella, you can now place an Impella 5.5, put that
Mhm.
in, directly vent the LV. And so now you're not having that swirling. Now you're keeping the LV unloaded. And so the heart's not working as hard. So you have Impella and ECMO working together.
Yeah, I get it as the vent, but if just ECMO by itself, I mean just Impella by itself, no ECMO. I mean nobody's saying ECMO, we're just saying Impella.
Mm-hmm.
So say this is a bridge to transplant patient. Like that's not considered ECMO, that's like a
Nope.
VAD, right?
That is just an intracorporeal bag.
Yeah.
That's
Okay.
just Impella.
Okay. Okay. Because it gets a little confusing. Because for us, if a patient, ECMO is considered CPR, so we do emergent salvage, just as if they were having chest compressions on the way to the OR. And it doesn't drop our cases from the risk model, but it definitely increases the risk. So you go from emergent to emergent salvage anytime you go. Um, it's just, I don't know,
That's an interesting
sometimes.
definition.
Hmm. Yeah, we get to, and I think it's just, I mean, maybe I'm interpreting it wrong to say, but it is considered, you know, whatever your extreme measures to get your patient to the OR. And it does affect our risk model.
I mean, it definitely does. I mean, it does increase your risk for your patients
Right,
preoperatively
as
if you're on
advisor.
ECMO prior to.
Any other questions for Dustin?
Yeah, Judy, I'll jump in with a question. So, Dustin, you and I were chatting just a little bit before the meeting today, and I just was wondering if you could share a little bit more about some of the potential opportunities for, for instance, centers within Virginia to collaborate via the ELSO database and infrastructure.
Oh, absolutely. So with this new change and going over to Domo and literally kind of also listening to its users, kind of, I would say maybe finally, they've kind of been stubborn over the years, but I think they've gotten a lot better as we've been a lot more vocal as a community. And right now, you're able to peer group yourself internationally to like centers. So if you're high volume, small volume, medium volume, or if you're some sort of center of excellence. So we're a platinum center. I can benchmark myself to platinum and gold. I can't benchmark myself to silver or a non center of excellence per se. But there are other things throughout the world, like peer groups, that we all kind of just found out maybe existed. And ELSO has now opened up that opportunity to everybody else in the community. So if 10 centers that are already ELSO centers are willing to come together, we are able to make our own peer groups. That means that we'll be able to use that Domo platform, and there'll be a button that says, let's say, Peer Group Virginia, that you can click. It's still uh, de-identified. You won't know who the other ones, whose exact data that is, but you're able to benchmark yourself against all of those centers. You're able to look at what our complications are in that peer group. You're able to see what our survival to discharge or survival to coming off ECMO is, or how people are having, what their dispositions are post ECMO within that peer group. And so now, with the change that's going on with the registry, with the quality committee, it's really a great time for those of us in the ECMO community to kind of come together because, at UVA, VCU, Fairfax, we're the largest high volume centers at greater than 100 cases a year here in Virginia. But none of us knows exactly who and how many cases are actually coming out of this state in this region. What complications are we seeing? What sort of trends are we seeing? Are we seeing a lot of kids with strep? These are the conversations that we are able to have if we all can kind of come together as a solidified peer group.
I just think that's super exciting, Dustin, and hopefully, we can start getting the word out there and understanding, how to get that peer group together. What sort of sign off do those folks need? And we can take the conversation offline, but just do we need
Sure,
like
I think as a bare minimum,
contracts
from what
or
I've talked to with ELSO and conversations I've had with Peter Reiches, it's the groups come together, they decide this is what they want to do. The medical directors and the ECMO coordinators for the specific programs basically would sign a joint letter to ELSO saying these are our wishes. We are willing to, add this to our data use agreement to become this type of peer group. Then from there, ELSO will look at that. It'll go in front of the registry committee and the quality committee to vote on, and then hopefully that is successful, and then they'll make us a peer group. I think at the bare minimum, if people are interested in this, feel free to email me directly or email Eddie or Judy or Sherry to kind of get in contact with me and we can maybe start some of these conversations. But I really feel this is very important for us in the community. And I think we already have really great knowledge sharing here through VCSQI. This is just another level to kind of add on to that.
awesome. Well, that is super exciting. I think Eve has her hand up.
Yes, thank you. I just wanted to, I guess I should introduce myself to this crowd. My name is Eve Dallas. I'm one of the perfusionists at UVA, and I work with Dustin whenever I have the opportunity because he always teaches me something. And I just want to say thank you for the presentation. It was really informative and helpful. And just to reiterate with the crowd, if you have involvement in any way with your day-to-day business, with your folks that are doing ECMO and your perfusion teams, please do reach out to them and express, tell them what you've learned today regarding this new peer group opportunity. I just wanted to reiterate that. I know that a lot of medical directors around the state have kind of lamented the inability to do this kind of research and to do this kind of outcomes work for years. And this is a big step for ELSO, as Dustin said. And, we're excited about it. And we hope that your folks will be as well. And then we can get this group put together and affiliate it with the VCSQI and give them the opportunity to platform this just really blossoming means of taking care of the absolute sickest patients that we see. And so thank you, Dustin, for that presentation. And hopefully we can get this program going and headed in the right direction. Thank you.
Justin, we have friends from all over join us on this. Is this something that needs to really just be geographically like close? Like, could our friends from North Carolina, Maryland,
Yeah, I would love.
Michigan?
I don't think it just needs to be Virginia. I think those that are participating in VCS, our other local partners are not just within the state. There are patients that come from or go to North Carolina. There's patients that we have to send out. I mean, for me, it's anyone here within the Mid-Atlantic region would be a great peer group for us. And we would have to. The minimum number is 10, and we don't have enough ELSO contributing centers just within our state to fulfill that. So we would have to go outside anyway. So for me, it's really anyone that wants to participate would be extremely helpful to this.
Because we have friends from all over. Eddie, do you think this is something you could take to the our Maryland friends too?
Yeah, I'm thinking Maryland, North Carolina with our Perfect Care collaborators.
Okay, yeah.
Those would be two
Okay.
kind of low-hanging
Okay.
fruits that we could
Um, and
think about.
Denise is saying that her group at Centera, okay, good. They got together because Centera, that would be so interesting. Dustin, do you have a sense of this? There's an added cost for this, or is this
No
just
added
we're gonna
cost. You're
because you're already
already
doing
people are already paying like money per year as an ELSO center. I think it's like
okay.
$500 a year already. There's no cost to this, not at all.
And are there any restrictions on publishing from this data, or is it
Yes. So that's all part of, anyone that works with ELSO and is a data registrar for ELSO, your data use agreement. Anything that comes out of Domo is not publishable. And
okay?
so if us as a collective wanted to publish something, we couldn't use the graphs and the things that come from Domo, but we could pool and export our own ELSO data and play with it together. And as long as we have the appropriate IRB and all that other sort of stuff, we'd be able to publish off of it. You just can't use the Domo technology and use the graphs from that technology to publish anything with it. And you also can't use the benchmark data from ELSO. So I can't get the ELSO data to benchmark, oh, I want to see 70-year-olds that go on VV ECMO for this, and then get that number from ELSO and publish it and say I use the ELSO registry. You're not allowed to do that. You can use the ELSO international summary to get that because that's public information. If you want to publish using ELSO's actual data from ELSO, you have to have an ELSO approved project through them. But if we had a peer group, we are willing to share our own information with each other as long as we're not using anything proprietary to them.
So you could use those 10 sites or however many you get, right? You could use your peer group as a benchmark, or say you wanted to look at strep and baby or whatever it is that you were
Correct.
interested in, then you could actually do that because I mean, to me, that's incredibly exciting. Brandy did write you too. I think you must.
Oh, we met at the last VCSQI meeting.
Okay, there you go. Okay, there you go. So, all right, that would be awesome. And maybe we can find an over Fairfax friend. Well, Eddie, I'm glad we started out with Dustin. What other questions for Dustin? We have a minute or two here. I will say that you have to be on ECMO actually in OR entry. I just had a patient that they'd been on ECMO but then came off before their OR entry, so then it just goes into their history, and there is a spot in the previous CV interventions to put ECMO because they didn't go to the OR in it, and it does make you salvage. So I think I think coding it is always kind of interesting. Any other questions for Dustin? Well, Eddie, we will, I think everybody's got a copy of their outcomes, and we can maybe share at another meeting.
Yeah, sounds good. I don't want to crunch anybody's schedule here. So we appreciate you, Dustin. Thanks so much for being with us today, and looking forward to continuing the conversation. And hopefully we can get one of those peer groups set up here in the near future.
Absolutely. Thank you guys for having me. I very much appreciate it.
Thank you.
Fantastic. Thank you so much, everyone. Have a great rest of your afternoon.
Thanks, Eddie.
Take care.